I just want to welcome our speakers today. This is a very unusual colloquium. We have 4 of you we speak today, and we value your time and welcome you to this meeting. This is an NSF Expeditions meeting that happens every 2 weeks, and we have had some wonderful speakers in the past, and I think your talk is going to be very well received as well. But I'm going to let Anil do the introductions, but I want to thank you on behalf of the entire Expeditions team for taking the time to speak with us.
Indeed, it's my distinct pleasure to welcome our very distinguished speakers from a perspective that we are really interested in. So I'll just briefly introduce our speakers. So Lauren Marks heads USG partnerships for Johnson & Johnson Global Public Health, and today she'll be talking about J&J efforts to understand and combat vaccine hesitancy across the African continent by leveraging data and behavior science alongside private sector capabilities. And then Sunny Sharma leads the global health practice within Ipsos UK, and Rebecca West is a research manager in global health at Ipsos UK. They will discuss a segmentation study of unvaccinated adults in Kenya, Nigeria, and Zambia, and recommended message strategies. And Kenneth Davis is a new business manager with Fraym's global development team, and he'll discuss geospatial analysis of COVID-19 vaccine uptake. So Lauren, whenever you're ready.
Great. Thank you for that introduction, Anil, and thank you again for inviting us to come to speak to your group. We're really honored, and we're excited to share some work that we've done as Johnson & Johnson Global Public Health together with some of our partners, Ipsos and Fraym, who did this work with us to try and increase the willingness to vaccinate for COVID in Sub-Saharan Africa. I know that that may not be the explicit remit of everybody in this group, but we hope that there is interest in the methodology and the approach that we took, and that it can be applied in other contexts, whether that's domestic or global, and whether that's any sort of health areas. I come from a part of Johnson & Johnson that is called Global Public Health. And my organization kind of sits in between the business or commercial side of Johnson & Johnson, the pharmaceutical company, and the philanthropic side. And our model is really about using the capabilities and the expertise and the resource and innovations of our company and applying it to global public health. So you'll see some of those capabilities and expertise represented here today, primarily folks who come from our consumer business and have used these research strategies to help understand consumer behavior. And in this instance, we applied those strategies to increasing COVID vaccine uptake. But again, it's the same strategies we would use in our business as well. Our mission is really to make our innovations available, affordable, and accessible for low and middle income countries and underserved populations. So I want to give a quick snapshot, an overview of the process that we use when we are trying to increase the demand for health-seeking behavior. I've kept this slide fairly neutral because I think it can be applied to any health-seeking behavior that you're trying to change behavior on. We think about it in 3 phases: the research and insights phase, the strategy phase, and the test, learn, and optimize phase when we're actually implementing. Today's talk is really going to be focused on that first section of research and insights. And we're going to share a couple of research studies that we did to help us understand why people weren't getting vaccinated for COVID, who we needed to really focus on, both demographically as well as from an attitude and behavior perspective, so we could start to understand the audience that we wanted to communicate with, and then some geospatial analysis to understand where those populations were physically located and what different channels of media or other channels might best reach them. So we'll be talking about those 3 blue boxes there, just to let you know that we then took that, turned it into a strategy for developing interventions, and then started to test those in market and actually implement some of those interventions in Sub-Saharan Africa. And that's the kind of end-to-end journey of how we would connect research to implementation. So now taking that down a level to what we specifically did for vaccine confidence, we realized early in the pandemic that the existence of vaccines was not enough to guarantee vaccinations, and that we would need to do some work and really understand populations to be able to strengthen their confidence with the end goal of improving vaccine uptake. So our GPH organization worked with the two organizations here, Fraym and Ipsos, to conduct a number of research studies. They are unbranded. They are not specific to the J&J vaccine. They are just meant to build vaccine confidence overall. But we really wanted to improve our own understanding of vaccine confidence across Sub-Saharan Africa and look at how it changes. And it's again meant to be in service of other country governments, donors, partners, NGOs who might be able to use this research to increase the effectiveness of their campaign. Again, these are kind of overviews of the research that we're going to share today. We used an underlying framework called the 3 C's. It was developed by WHO. It said there are 3 main barriers why people weren't getting vaccinated. One being convenience, whether the vaccine was available to them or close or easy for them to get. One being confidence in the safety and efficacy of the vaccine, belief that the vaccine actually worked. And the third being complacence, whether the vaccine is relevant to their own lives and whether they need it. We used that as our really foundational research, and Sunny's team at Ipsos helped us create a population segmentation that's based on attitudes and behaviors as opposed to demographics. And Sunny and Rebecca will go into detail on what we learned through that segmentation. Skipping the middle one, Sunny and Rebecca will also talk about some message testing, where using those segments, we started to do some learning and research on what kinds of messages we needed to say to change attitudes and behaviors. What could we say to move the needle on people's willingness to get vaccinated? And messengers, who do those messages need to come from? And then going back to this middle piece, Kenneth is going to share some really interesting geospatial analysis that helps us map a very granular level down to the square kilometer where these populations are located, so that we then have a much more nuanced understanding of where to find each of these population segments so we can target and tailor our communication strategy. As you listen to these presentations, the takeaways that I hope you'll come away with are the importance of doing this sort of research and gathering these insights to understand an audience before designing interventions. I know many of you are in the research space, so that probably goes without saying. And then the second point being that communication we view as a rigorous science that should be built on evidence, research, and data the same way any other intervention is, and should really follow those same principles and approaches of program implementation. So with that, I will turn it over to Sunny and Rebecca to share our segmentation study and the message testing.
Hi, everyone. Nice to see you today. So Sunny and I will be talking about, as Lauren mentioned, the segmentation and the message testing studies, which we conducted to look at increasing willingness to vaccinate in Sub-Saharan Africa. What drove this research was the fact that COVID vaccine uptake really was lagging and still lags in Sub-Saharan Africa compared to the rest of the world. And we understood that vaccine hesitancy is one of the primary drivers of this. So we conducted 2 streams of research in Kenya, Nigeria, and Zambia to understand if willingness to vaccinate could be increased and how best to increase willingness through messaging. And we'll walk you through both of these studies. So first, just a brief kind of high-level overview of the 2 pieces of work. In August and September 2021, we conducted a segmentation of adults who had not yet been vaccinated for COVID-19 in order to identify subgroups with similar attitudes and beliefs around vaccination, and also to identify both the perceptual and practical barriers to uptake that they experienced. And we also wanted to understand how large each of these subgroups was. Then, using our findings from the segmentation, we conducted a message testing study in the fall of 2021 to then try to understand which messages were the most impactful at increasing openness to get vaccinated, and also to examine any similarities, differences that we saw across segments and across countries. So I'll hand over to Sunny to walk you through the segmentation.
Thanks very much, and thank you for inviting us to speak here today. I'll give an introduction as to what we mean by attitudinal segmentation, if you want to move to the next slide, because I know it can mean different things to different people. So segmentation is a practice which we borrowed from commercial marketing, and we've applied it to global public health challenges now. The first one I did was back in 2014 for a HIV intervention in Zimbabwe. And we've been doing them across different health challenge areas, primarily in Sub-Saharan Africa and Asia since then. It's based on the underlying premises that all human beings were not the same as each other. We're not a monolith. Everybody on the call will have different hobbies, different ways they like to unwind, different things that interest them and that scare them, and different dreams of the future. And similarly, taking that into consideration, our beliefs and intentions towards taking the COVID vaccine are not the same as each other. We'll all have our individual reasons for why we want to go for it, and possibly some things that scare us about going for it as well. So to make sense of this complexity and of this noise, segmentation is a statistical tool which we use to cluster groups of people together whose commonalities with each other, they will share similar attitudes and beliefs and behaviors towards taking the vaccine. And through being able to build this model, we're looking to support the public health community, focus and tailor the most impactful messages to those who need it the most, and also to allow them to be able to plan their resources based on the size of what people's barriers are within the country as well. An example that we typically use when we go into a country and we're explaining attitudinal segmentation for the first time, we use the examples on the right here, which are of two different car adverts. Typically, people who buy cars in showrooms, the overall decision maker is still men in many of the situations. And demographically, both of these adverts are targeted at people of a similar demographic background, so likely to be male, probably on a middle to high income. But what they want from the car is fundamentally different. And the first thing that salesperson is going to ask you when you enter a showroom is, well, what brings you here today? Because they know if they're going to stand and present to you 20 of their cars, it's nowhere near going to be likely to be as impactful and have a better chance of a sale compared to if they ask you a few simple questions up front to understand why you're actually there. So if you were to come in and say, well, I use the car to take my family out on the weekend. We have children, 3 young children. We like to go out to the country and play games and have picnics. The salesperson knows they're not likely to have a chance of success if they're presenting you with their models of 2-seater sports cars. So they're probably going to be showing you something spacious and economical, like the car on the top advert as well. And what we're looking to do with the segmentation is understand up front, well, okay, so what is it that people are actually concerned about or driving them towards the vaccine, so we can be having relevant conversations with them when it gets to that point, either through mass media or enhancing those relationships between healthcare workers and target recipients of the vaccine as well. So there's multiple purposes that come with creating this type of model. And what we're looking to do when we develop this model is to understand, well, who are the groups of people who, if you're rolling COVID vaccines out into a country, have already bought into the argument for why they would want to vaccinate. When we did this segmentation, it was in August of last year when COVID vaccines started landing in Sub-Saharan Africa in larger amounts than had done before. But that doesn't mean that the population hadn't already seen plenty of media and news from overseas about the vaccine and had experienced the pandemic for 18 months. So we knew as these doses were coming in, there was going to be a proportion of the population who were already bought into the argument that they wanted to vaccinate. So on that top spectrum, they would be on the right, whereas some others might be a bit more hesitant. And that's what we're looking to be able to tease out and the underlying reasons behind it. We chose 3 locations in which to launch this segmentation that offered different types of challenges. Kenya was one of the countries we chose. We picked it because there's a relatively high population, and with routine infant immunization, it's relatively high compared to other sub-Saharan African countries too. So we have the working hypothesis that this is a population who have already bought into vaccines as a cultural norm, and therefore offers a distinct difference to Nigeria, which has a similarly large population, but kind of medium to low routine immunization when it comes to infant immunization across the country as well, particularly in some of the states in the center and the north. So we thought that would be a nice contrast between them. And we also picked Zambia to have a coverage of a Southern African country, which was somewhere in the middle of Kenya and Nigeria with underlying norms about vaccine. We spoke to 800 unvaccinated adults per country, looking for an even split of genders and letting age fall out naturally. But we also looked for an even split of poverty and income levels as well. Just to mention, our methodology that we did in Nigeria and Kenya was telephone data collection, which is not our preferred because it's not as gold standard as doing random walk techniques and face-to-face, but because of the way the pandemic was at the time with the second wave, we couldn't send interviewers face-to-face. It was relatively safe to do so in Zambia, so we did manage to do face-to-face data collection there. So as Becca mentioned at the beginning, we're mainly focusing on the methods that go into it for this. There is more information about the actual segments, which you can ask us for afterwards, but we are focusing on how we designed this. Because of the need for attitudinal data to be relatively quick, because doses of vaccines were landing in large quantities in August, we didn't start with a usual qualitative phase that we would. We developed the questionnaire based on literature review and from what we knew from previous studies about immunization and COVID vaccine across the countries in which we were working in. But the types of variables that we looked to test in the segmentation question, you use demographics, not to segment people because we're segmenting people on their underlying attitudes and behaviors, and demographics only tell part of the story. But it's good to get a sense of, is there any of these segments that are skewing towards certain demographics? We also wanted to test general perceptions of the pandemic, how much trust do people put in the communities in which they live in and media sources, who do they go to for advice for health matters? This is important for us to be able to advise on what messages about COVID-19. We also wanted to understand how much of an impact the pandemic had on them, what's the perceived risk of getting it and the severity of getting it, and then also how likely are they to take the COVID vaccine and which speed. How easy did they think the process would be and what communication channels they're listening to? I should say that when we design a segmentation questionnaire, we're deliberately looking to tease people apart on their underlying attitudes. So most of the questions are based on a Likert scale, usually a 5-point Likert scale. So if you're asking somebody about their perceived risk, you might say on a scale of 1 to 5, how at risk do you feel you are of getting COVID, where 5 is very much so at risk and 1 is not at all at risk, and then the various shades in between it. So we're looking, when we're actually doing the analysis, to work out when you've teased your groups of people, how many of these variables are they all sharing the same opinion or behavior or whatever it is together to be able to generate these 5 discrete segments. And the ones that we found were actually teasing people apart and putting them into different groups is their underlying trust that they have in the community, how they make decisions about protecting their own health or where they go to when they are in terms of poor health, how they feel about the pandemic in general, the impact of the pandemic and their attitudes towards the risk-taking precautions that they're having and the vaccinations. And the final one, so what are their underlying motivations and barriers towards the COVID vaccine as well? So they're the inputs to the segmentation. Once we have collected the data, it then goes to a team of statisticians who sit within our unit, and they will be looking at understanding the relationships between the different variables and how, using the latent class analysis and the regression analysis, these groups are all overlapping with each other in what they share in common when it comes to their attitude, willingness to take the vaccine, and other factors that link them together to make a distinct segment. They typically will present to us several different models which come out, all with varying degrees of statistical robustness. The segmentation is a mix of art and science. So we want something that is true to real life, but we also want something that we can take to people in country and they'll recognize, oh yeah, I know a segment 1. I know a segment 3, my mother is a segment 2, and we'll recognize them as personas so that when we're designing solutions to support these different groups, they can picture who it is, what the nature of their challenges and design. So it's the mix of the art and the science. What came out of our analysis? There were 5 distinct segments. I won't go through them in detail because I know we have 2 of the speakers, but just to give you an understanding, segment 1, this was the one which I was describing would be the very early adopter. They were convinced of the threat of COVID to themselves and their own health, and the benefits of taking a vaccine. They would be driven by wanting to have the social responsibility to protect their community. The extent to which these were in each country varied. So Kenya had the largest proportion, whereas Nigeria had a relatively low one, which was expected from our initial hypothesis as well. However, our advice for when you have a segment 1 is that we know social norms really drive vaccinating behavior within communities. So once your segment 1s are coming through the door, if you could give them badges to show that they're vaccinated or something they could show on their phone or social media, that will be helpful for some of the other segments, particularly the complacent ones. Segment 2, so this was one who we tend to be stuck in a bit of a cognitive dissonance because they were really worried and nervous about the threat of COVID, but they also had lots of safety concerns about the speed in which the vaccine was developed. So they were nervous about COVID, but they weren't necessarily seeing the vaccine as the safest way out of it. So if you were to meet a segment 2, you'd need to reassure them on the safety tests that have happened with the vaccine because they're stuck in this phase. Segment 3 was a bit more resistant. Well, 0% of them said that they would be willing to take the vaccine today. So they were much more resistant than the other segments, but they typically were hesitant of COVID as a threat and also had mistrust in the authorities and communities who were promoting COVID vaccinations. These types of people typically tended to live in informal settlements in the outside of cities. Perhaps they were really affected by lockdowns, which took away their ability to earn without much care given to them for their financial problems that they went into. And therefore they were resistant and hesitant about everything to do with the pandemic response, including the vaccine. But they didn't actually question the science behind the vaccine, more mistrust in the authorities that were promoting them. Segment 4 was one who was the convenience segment. So they were convinced of the COVID threat and merits of the vaccine, but they were inhibited by practical barriers, particularly the length of time it might take to spend in a clinic and any foregone earnings. And finally, segment 5 was the much more complacent one. So not particularly against the vaccine, but not particularly worried about the threat of COVID either. So they would need a compelling enough reason to be able to go for it, but we think they can be moved by social norms. Pass on to Becca.
Great, thanks, Sunny. So we'll walk you through the message testing study now, and this built off of the segmentation. So we conducted the research in the same markets, slightly bigger sample, but just over 800 respondents in each market, and with a similar screening criteria, so an even male-female split. And the way we did this was that we looked at the segmentation globally, but also by market based on what we understood to be the fallout of each segment in each market so that it was representative of how we think the segments actually would be in each setting. And we did boost some areas where maybe there was a very small segment because we wanted to have a robust enough sample across the study, but that was generally how we approached sampling for this second piece of research. So we worked with a creative agency based in Kenya to design a number of messages, and we also had different messengers that we wanted to test. So there were 2 types of messengers and messages. The first set were expert messages, and those were delivered by people who were experts in COVID or vaccination, who were likely to be trusted sources of healthcare information. So our expert messages were delivered by doctors, nurses, WHO officials, pharmacists, community health workers, and government officials. And then our non-expert messages were delivered by those who were trusted sources of information in community and likely to be influential to somebody's decision making, but who were not healthcare experts. So these were a family or friend, community leaders, religious leaders, and music or sports celebrities. And we used discrete choice experiment, which is a technique often used in economics, in the private sector. And this is an attribute-based method to measure preferences and trade-offs of respondents in order to elicit preferences. And we had just over 50 messages and all of the different messengers on the previous slide. We tested over 700 different message combinations using this discrete choice experiment. And we had respondents evaluate 14 pairs of messages each. And in each pair, they selected the message that they felt most motivated them to get a COVID vaccine. And I should mention that what we were hoping to do in this research was play audio clips of each message being delivered in theory by one of the messengers. but there were some challenges actually making this happen in the field. So we did instead have interviewers read out a statement such as, "I am a male health official and I will give you the following message." So that was a slight limitation to the design, but we actually tested by interviewer gender as well to see if that influenced respondents' choices at all, and it didn't have any impact. So based on looking at the preferred messengers that each respondent selected, we were able to generate utility values for each attribute. So the actual text of the message itself, the type of messenger, and the messenger's gender. And we could compute these utility values by each market based on the winning choices. We also measured baseline willingness to get vaccinated and then end-line willingness to get vaccinated after the respondent evaluated their preferred messages to try to measure how much we could move the needle towards willingness to vaccinate with each of the most preferred messages. And you can see here, I've laid out what we found in terms of increasing openness to vaccinate across each of our segments. And we found that segment 3 was the most movable by 14 percentage points. We found that we were able to move from a 16% openness to 30% openness to vaccinate with the most optimal message combinations, and segments 2 and 5 were the most movable as well. And so this was a really, I think, an interesting and important finding for us, because the segments that we were able to move the most were our cynics, our skeptics, and our ambivalents. Our pragmatists and enthusiasts were harder to move, and we guess that this is largely because they're already open to vaccinating, so there wasn't much movement. A message wouldn't change their willingness to vaccinate much, but we did see that among our more cynical and skeptical segments, we could get some movement towards willingness to vaccinate. And we also just want to include information on this distribution of each segment by country, so you can see the differences and how those fall out in each market. So ultimately, we had over 700 message combinations with utility values to rank. This took a lot of sifting and, like Sunny said, both an art and a science, I think, with interpreting the results of a discrete choice experiment as well, and looking for trends and insights that come out of ranking all of these different messages and message attributes. And so some key learnings that we took from the message testing work were, first, that messages around altruism and community spirit were the most motivational across all segments and markets. And successful messages used a technique of reframing the role of vaccines to address complacency among our segments who were less willing to vaccinate initially. We also found that public information messages needed to include some kind of emotional appeal or call to action in order to motivate people to get the vaccine. And we found a real preference for expert messages across all the countries we did this research in. We also found that simple language is key. It's important to explain how the vaccine works in an easily accessible and jargon-free manner. So the simpler the message, the more effective we found it to be. While I did just say that expert messages were the most preferred across countries, we did also find that there is still a role for non-experts to deliver messages, and there were some interesting trends by country that we dug into. For example, in Zambia, non-expert messages were really, really popular from community leaders and religious leaders. But across all markets, we found that celebrities and sports stars were some of the least preferred messengers, as well as government officials. So we have been doing some digging into that and thinking that it may likely be around both trust as well as the potential to influence your decision that these messengers might have. And lastly, we found that fear-based messages, like messages referring to the dangers of long COVID or losing a relative, were seen as some of the least motivating in our sample. So I'll stop there for now. I know we are going to hear from Fraym as well. Feel free to reach out if you'd like to talk about this research with us further as well.
Thanks. I guess I'll just jump in then. So I'm Kenneth Davis with Fraym, and Fraym is a technology company and small business based out of the Washington, D.C. area. And I am a new business manager. I lead up our global health portfolio. And I'm really excited to be talking to you all today. And what I'm going to be sharing is the work we also have done with J&J GPH, and it also builds off of the work that Ipsos just presented. So what we did in this project is basically 4 steps. First of all, we mapped hesitancy using our machine learning process. And so what this means is we used survey data and satellite imagery, and we mapped down levels of hesitancy as hyperlocal estimates down to the 1 square kilometer level across a number of countries. And then we analyzed the drivers of hesitancy. So very similarly, we were using the 3 C's model. So asking questions around vaccine hesitancy and grouping the answers to those questions into 3 buckets: confidence, convenience, and complacency. And also mapping those indices down to the 1 square kilometer level. And then segmenting populations. Basically what we did is we tried to map those 3 C's to the same questions Ipsos was asking so that we could mirror and create estimates of their segments at the 1 square kilometer level, so that you'd have an idea based on all the research and analysis Ipsos and J&J GPH did on those segments and did on the message testing, could also be used through this hyperlocal mapping, so that we could get an idea of where those segments are more likely to be within a country. And then the final part is deploying all this data via our web-based dashboard. It basically allows you to explore geospatial data at the 1 square kilometer level, a lot of different layers at one time without any GIS expertise or sophistication, so that partners can integrate that into their programming and decision-making and resource allocation. So really quickly, broadly, the geographic reach of this, we worked in a number of different countries: Kenya, Nigeria, South Africa, Ghana, and Ethiopia, Zambia, Uganda, Malawi, Mali, Rwanda, Nigeria. And there's 2 very distinct ways we approach this. In the first group of countries, the COVID-19 model countries, we actually were overseeing the collection of nationally representative household survey data that asked questions specific to COVID-19 and vaccine hesitancy, either in 2021 or 2022 or both. Kenya, we actually had a survey in both years, so we're able to also show change over time data at the hyperlocal level. And then in the next group of countries, we used what's called the proxy model. So we used existing nationally representative household survey data. This included the primary input was the demographic and health surveys, the latest one available in the country, supplemented by the most recent Afrobarometer. And in Nigeria, we actually started with the proxy model and then later created a COVID-19 model with 2022 data. So we're able to also analyze the different things those models were finding and the different ways they're useful. This presentation is going to focus on Kenya and that change over time data. I'm going to try to be really quick with the overview and then jump into a demo. So a quick bit about our process. This is basically the 4 parts of it. So what Fraym is doing is we're combining survey and satellite data. What that means is we're acquiring all the relevant nationally representative surveys. We're overseeing these surveys ourselves. They are nationally representative, they're spatially representative, they have nested quotas based on age, gender, region, as well as socioeconomic characteristics. We combine all that with satellite imagery, as well as remotely sensed data from satellites, such as Earth observation data, like nighttime illumination, building density, soil characteristics, and up to many more, up to 100 different satellite indicators. We then harmonize all of those data sets, clean them, validate them, geospatially enable them if necessary. And then we run them through a series of different machine learning models that we choose based on the geography, the context, and their performance as we do a very intensive QA/QC process for each of those indicators. And then the final product is, as I shared earlier, those hyperlocal estimates at the 1 square kilometer level for the individual indicators, so those questions that were asked in the survey, as well as models we put together or estimate, like for in this case, the segments. So we're combining these different indicators into the different indices and then using those to estimate the segments if so shared down to that 1 square kilometer level. And then we aggregate up from there as helpful to key decision-making levels. I won't go into this since Ipsos already did a brief overview and many of us are familiar with it, but again, our indices that we created are based on the 3 C's as kind of outlined and promoted by the World Health Organization and the SAGE working group on vaccine hesitancy. And basically how we mirrored those segments, you'll see the same segments that Ipsos created. We're just bucketing them into, confidence enthusiasts, for example. If an individual has a high score of confidence, high score of convenience, and low score of complacency, then they are placed in the confident enthusiast bucket. We originally did this based on a little simpler to make them discrete, but we weren't able to go to 100% of the population. So we then used multivariate regressions to predict the probability of someone who didn't fall into the exact segment of belonging into it, and used regression methods to create the final categories that had 100% of the population coverage. Also, just to flag here, we collected this survey data before we started working with J&J in Kenya. And so the questions are not identical to the ones that Ipsos was asking. These are very much estimates, trying to mirror it, giving us a good idea. And the data were collected at different times than when Ipsos was collecting data. And of course, some of these countries are not the same, so there are going to be some differences there. Really quickly, I'll show you what this looks like and give some high-level outputs. This is our confidence index. So we'll see there's been some minor changes over time. So you'll see in Mandera, there was a significant decrease in confidence in that area, but overall not a major shift. Same with convenience. There's some minor shifts around the country, a few areas that have changed significantly, but where we saw the biggest shifts are actually in complacency, where we see in Kenya to the northeast, we originally had an area of very, very high levels of complacency. And then the shift this year is that that area is now much, much lower in levels of complacency, but we have much higher levels of complacency to the center west of the country instead. So some interesting shifts going on there in complacency. And overall with the segments, early on when we used our April 2021 data, we found that this is a map of the most common segment within a community at the 1 square kilometer level. And so we saw the vast majority falling into the enthusiastic pragmatists bucket in April, but as of February 2022, we have a much wider variety of segments. So we're finding a much higher density of COVID cynics in some areas, vaccine skeptics in other areas, and a reduction in confident enthusiasts and enthusiastic pragmatists being the dominant segment in a community, and some pretty significant geographic variance there. So this is our dashboard where we're deploying all this data. And so I start with just the county level, because this is often when we're using nationally representative household survey data. It's usually only representative at this first administrative level, especially for something like a DHS. And a lot of the available COVID-19 dashboards are displaying data at this level. It's hard for those surveys to be representative below this level. But what our machine learning estimates are allowing us to do is really see a tremendous amount of data that's lost at that higher level. So this is the same map, which is COVID-19 vaccine hesitancy. So this is individuals as of that Q1 2022 survey that are saying they are not, or they're unsure whether they're going to take a COVID-19 vaccine. So we're classifying all those individuals as overall hesitancy. And you'll see there's a lot more variance at this ward level in Kenya than there was at the county level. And then of course, as I showed earlier in some of those static maps, we can pop this down to the grid level and see a very different picture. So you'll see the amount that's lost at that even the ward level. There's a tremendous amount of insight that we're not able to get. And these grayed out areas are areas where we have a population being lower than 30 persons per square kilometer. That's why they're grayed out. But you'll see if we zoom into a specific area, a specific community, and then as I just showed, that grid level of how much granularity is kind of missing when you're not zooming in and really getting that data at the more local level. And the things our partners are using this for is, so say, based on the research Ipsos and J&J GPH have done with message testing, and they're sharing that information with partners. So they want to focus on perhaps enthusiastic pragmatists. So I'll switch, right now we're just looking at hesitancy overall, but I'll switch to enthusiastic pragmatists overall. And then we want to focus on wards that have a high level of those enthusiastic pragmatists. So we're going to filter out areas that show a minimum of 20% of the population is categorized as an enthusiastic pragmatist within a ward. So we can start by that. And what we'll see is it starts to gray out some of the wards that don't meet our parameters. Okay, so we wanted, we've just been donated, say, Facebook ad buys. And so we'll look at where we have at least 50% of the population within that ward is also a Facebook user. So again, we're going to slowly cutting through where are the areas that are going to have the most impact. We might want to go further and say 65% and increase the segment a little bit to 30%. if we want to really prioritize our resources for these Facebook ad buys, now we see just a few wards that are going to have the greatest impact. And one thing to highlight here is each of these wards, counties, or individual pixels, if we're at the grid level, we're able to see all of this different survey data we've collected, whether that's demographic breakdowns, the segments, as well as the individual channels I'm showing here. So I've got some of the top 3 of most popular of all these different platforms. So social media, radio stations, television stations, newspapers, language spoken, as well as religion practice, to kind of zoom in and hone in on where we want to message. So, maybe we want to do that Facebook ad in a larger area, but we want to only do it in Swahili. So we want to see the wards where Swahili is the dominant language spoken. And we can, of course, do the same thing at the grid level. So if we switch to that, we can also gray out those communities that aren't reaching the parameters we'd like to further. But I'm going to stop there because we've only got 10 minutes left for questions. And I'm excited to hear your thoughts and feedback and questions. Thanks all.
Thank you. This is a great talk by all of you.
Yeah, thank you so much to all our speakers for a wonderful talk. I'll just open the floor for any questions.
I had a couple of questions. So thanks for the nice talk. This is Aditya Prakash from Georgia Tech. So one question was, is this a dashboard public? I guess that's one of the things, if we can have a look at that.
Yeah, the dashboards are semi-public, which
okay.
just means that because of the granularity of the data and the sensitivity of the data, it's not public access. But it's basically J&J is meeting with people, meeting with implementing partners, researchers, and determining if they have a vested interest in supporting vaccine hesitancy and increasing vaccine uptake, then they grant access to these dashboards.
Cool. Thanks so much. So the other question was these compartments. Should we think of them as fixed, or have you seen a movement of people from one compartment to the other, right? And are your surveys able to capture that?
Yeah, we saw significant shifts in where, the level of segments around the country, the level of hesitancy. And if we looked at the individual indices, you'd see major shifts. I showed a lot of those maps at the grid level, but even at the ward level and the department level, we saw some fairly significant shifts and interesting findings. And it makes sense. I think our methodology in particular was driven by one of the questions we asked related to confidence, which is, do you trust the vaccine to be useful against future variants? And so as a result, the way we did our modeling, it plummeted vaccine confidence over time, which really shifted how some of the folks fell into segments and the levels of confidence we saw across the country. So that was driving our models quite a bit in Kenya in particular, because of that decreased confidence in the vaccine being useful in the way they expected it to be useful.
Correct. Exactly, and I would be really curious to see the correlations of these movements to the dynamics of the disease itself. Depending on what was the intensity of the disease in those areas at that time. So another final question, I won't take too much of your time. Have you also seen how these compartments are varying across different countries? The reason I asked that is I wanted to see if you have thought about the role of cultural context for some of these segments, because that varies heavily from country to country, right? Some are prize more individualism, some prize community behavior and things like that. So I was just curious if you have seen any distributional shifts there. Thanks.
For us, it's very different depending on the country context. I think Sunny might be better off, though, since he really did the analysis on the cultural context for the segments.
Yeah, and we did see the primary actual cultural difference that we looked at communities was how much of a social norm was infant immunization already. Clearly, there are other social constructs which influence vaccine driving behavior, but one of the biggest ones that we look at correlate when it comes to the COVID vaccine is social norms. All 3 countries in which we conducted the research, and Becca, jump in here, when it came to the message testing, when it came to messages that were about protecting your own health, they resonated less than when it comes to protecting the most vulnerable around you, which is all coming down to the underlying cultural codes of Ubuntu and its different names that it has across Sub-Saharan Africa as well. Becca, anything to add to that?
Yeah, just that I think we also saw, we weren't able to look at really the granularity of the regional differences that Fraym did, especially with our message testing. But we could see that in Nigeria, for example, religious leaders were a much more preferred messenger compared to Kenya. So you could see some of those other cultural differences coming out in both in the segmentation and in the message testing research.
Cool. Thanks so much. Thanks.
Thanks, really interesting talk. So your strategy was more about communication, right? What kind of ads? Have you looked at like incentives? Did you try them out or did they help?
We did a little bit of desk research on incentives and nudges, and I think Sunny and Becca may have done more extensive research on that, which you can speak to in South Africa.
Yes, there's another extensive study that's still being analyzed from South Africa, so it hasn't been published as of yet. But in this message testing that we conducted, we did test some nudges. Becca, do you want to speak to that?
Sure. So in the message testing, we included a separate section at the end where we tested these nudges, and the nudges were more around kind of practical things or incentives that could help a person get vaccinated. So for example, one was get vaccinated and you'll get a voucher to use at a ShopRite, or we're providing free transportation to your vaccination site. And what we found was that they were universally popular. When we couldn't quite test them against the messages, but I think that was the key takeaway, was that messages that address people's, practical barriers to getting vaccinated were seen as quite motivating.
So did you try any monetary incentive?
In our nudge testing, it was just a food voucher or a bracelet, but no cash.
Okay, thanks.
So first of all, just absolutely brilliant presentations. Thank you very much for joining us. I have lots of questions and a few things that we have been doing that I want to mention, just so that we can potentially think of possible collaborations with you all. And it should just be taken as a sign of interest in our community. So of course, my first simple question is what Aditya had asked, but it's to Sunny and Rebecca, is the data something that you folks are willing to work with other partners, or it's right now, and I think for all of you, because the questions I'll ask are quite pertinent in terms of the kinds of analysis we could engage in with you all. So
yeah, research was conducted for the public good, so we have permission to share the research data with any interested parties, just as long as we know what analysis is conducting, so you can make sure it doesn't get misrepresented. But yeah, absolutely willing to share the data, no problem.
Okay. And when I say share, we don't want just the data. We would like to work with you folks to do the.
Yeah.
So that's really what I was meaning. So maybe I'll tell you a few things that relate to your presentation, Kenneth's presentation. Of course, by induction, Lawrence, you provide oral highlight and summary of it. So a couple of things. One, we have been supporting the Department of Health here in our Commonwealth, and we have developed some interesting methods to use COVID-19 dynamics, that models that we have developed for the state, to try and find ways to place mobile vaccination distribution facilities. So you can easily relate to the work you folks have done. It will, the convenience was the primary question we were trying to address, because we can't change the attitude at some point. And I think the method was quite successful. We have been working with them for a good 8 to 9 months. Mandy, who is here on the call, has done a lot of work in that direction, and we're happy to share. We have written a paper on this topic as well. So that was one. Second is, we have another line of work where we are trying to understand the question Aditya raised, in trying to take the data from Facebook surveys that CMU and Facebook have done together, and a few other surveys sets, to understand the dynamics of the hesitancy, because that goes in as input to our dynamic models. We try to assess the hesitancy at various levels. So that's the second part of the story. The third part, which is probably a little broad and connects to Kenneth's presentation, is we have been developing a concept of synthetic populations as well for US and for the globe, and it seems like quite related to what Kenneth presented. I don't know the details, so we'll find out more. We are starting to put out some of these populations in the open, and we're happy to talk about it. It uses the kinds of data sets you folks talked about, and the intent is precisely the kinds of analysis that you folks discussed. And the last thing, just yesterday, one of our papers appeared in PNAS on understanding usage of masks, by population. It's a theoretical study. It's not a study that takes into account the details you talked about. But I think we took into account both the epidemics and the social network structure to try and understand how mask wearing would change in time. And try to capture peer effects. We tried to capture impact of the fear that people might have. My feeling is that a model similar to this, not the same, of course, can be set up in the vaccine context as well, and understand who might take the vaccine in the first place. But I just thought I'll share all this information with you, with the goal, of course, of trying to find ways to work with you folks. I found the talk fascinating. Thanks.
Yeah, thanks very much. We'll be really happy to follow up on those.
Be wonderful. And I'll share other work as well. The state was very interested in placing these vaccine sites. It turns out to be a nice operations research question, but fits very well with the presentation you gave. So thanks again. Really appreciate the wonderful talks that you gave.
And you cover vaccine across different states, is that right?
Yes. So we've been doing a scenario modeling hub style work with CDC as well, Lauren, where we've been doing vaccine allocation. There's another paper we wrote on allocating vaccines based on not just the demographics, which what Mark and others had published recently, but using social networks as a basis to distribute vaccines. And I'm happy to share that piece of paper as well. It's quite interesting in what the results are.
Okay, well, thank everybody for joining us today, and we'll see you next time.
Thank you.
Perfect. Thank you.
Thank you.
Appreciate that.